5, 4, 3, 2, 1. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all on second day of Oncology updates. And for this, I would like to welcome Dr. Varun Goyal, who is Consultant Medical Oncologist, RGCI Delhi, for his welcome and introductory note. Over to you, sir.
Thank you. So Dr. Kumardeep is busy as usual. So I welcome you all the participants. Thank you for joining today, and thank you for John. Thank you all the pharma sponsors. So now today we are on the second leg of the oncology update, which we try to do justice and include major recent updates of different systems. So today we will discuss about the breast and lung cancer. And first talk will be by our own Dr. Kshitij, who is consultant medical oncologist and hematologist in HOC Vedant in Ahmedabad. So over to you, Kshitij. So he will discuss about the role of Trixana, role of these CDK inhibitors, and latest updates and survival benefit of this drug in metastatic breast cancer, advanced metastatic breast cancer. So I welcome you, Kshitij, and over to you.
Hello. Hello.
Hello. Yes, sir, we can hear you.
Hello.
Yes, sir, we can hear you. There's some issue at his end.
Ma'am, Dr. Kshitij sir is joining again. I think there is some network issue, so he'll join back.
Okay. Let's wait.
Dr. Kumardeep sir also had joined.
Yes.
Good evening, Dr. Kumardeep sir.
Good evening, Dr. Guru. Can we start?
Yes, sir. We have start. You just can give some welcome note, and till then, Kshitij will join again. There was some.
Kshitij is there?
Yes, Kshitij is here, just joining again. There was some network issue. Now Kshitij has joined, sir.
Good evening. I, Dr. Kumardeep Dutta Chaudhary, welcome you all on behalf of organizers. And today our first speaker will be Dr. Kshitij Damodia. He is a senior medical oncologist from Ahmedabad, and he will speak on hormone receptor positive, HER2 negative advanced cancer. Over to you, Dr. Kshitij.
Dr. Kshitij, we cannot hear you.
Hello.
Yes,
Yeah.
So
Yes.
am I audible?
Yes, sir. Very much.
Okay. Just a minute. All right. So just I'm sharing my screen.
Yes.
So is it visible?
Yes, sir. Now it's visible.
Okay. All right. Okay. Good evening, everyone. Thank you, Dr. Varun, Dr. Kumardeep, sir, for giving me this opportunity. Sorry for for that delay. So today I am here to present in front of you the data regarding Crixana, that is ribociclib, the overall survival data with ribociclib. So as we all know, ribociclib is indicated in metastatic CA breast, hormone positive, HER2 negative patients in both premenopausal as well as postmenopausal setting. In premenopausal women with an aromatase inhibitor along with ovarian suppression as the initial therapy, and in postmenopausal patients with aromatase inhibitor as initial therapy and along with fulvestrant as either initial or a second line therapy. Now, the objectives of this presentation will be to review the clinical evidence supporting the superior efficacy achieved with Crixana, to review the evidence of improved or maintained quality of life data, and to discuss what makes Crixana different from other CDK4/6 inhibitors. So, what we aim in our patient of a metastatic CA breast, we all aim in these three important things. We aim that our patients live longer. We aim that our patients live well with good quality of life. And again, we aim that they live longer without chemotherapy. And Crixana, with its current data, fulfills all these three important aims with good superior overall survival data, with good quality of life improvement, and over 4-year delayed median time to chemotherapy. So the important thing about Crixana is that it has been studied in a diverse patient population, including a variety of the first-line patients. So just in brief regarding the three pivotal clinical trials of Crixana, that is Mona Lisa 2, 3, and 7. So just a quick revision. Mona Lisa 2 was Crixana plus letrozole in postmenopausal women, first-line study. Mona Lisa 3 was Crixana plus fulvestrant in postmenopausal women in both first-line as well as second-line study. Mona Lisa 7 was Crixana along with an AI or tamoxifen with ovarian suppression in pre and perimenopausal patients in the first line setting. So it has been tried in both pre and peri as well as postmenopausal patients. It has been tried along with AI as well as fulvestrant. And with fulvestrant, it has been tried in both first line as well as the second line study. So what I am trying to make a point is it has evidence across a very diverse patient population. Now, the important aim is overall survival. And if we see the data of Mona Lisa 2 overall survival curves, the median overall survival was 63.9 months with Crixana plus letrozole versus 51.4 months with an absolute benefit of 12.5 months with a hazard ratio of 0.765. We can see a beautiful separation of the curves, and more importantly, we can see that as the time passes, the gap between the curves is widening. So as very well depicted in this particular chart, that at the end of 4 years, the difference between the arm was 5.7%, which increased to 8.4% at the end of 5 years, which further increased to 12.2% at the end of 6 years. A very important endpoint, that is time to chemotherapy. If we see this particular endpoint, and if we plot a chart of time to chemotherapy endpoint, the median was 50.6 months with Crixana letrozole versus 38.9 months, an absolute benefit of 11.7 months. So in short, time to chemotherapy delayed by over 4 years with this combination. We all know the benefit of progression-free survival of 25.3 months with this combination, with a hazard ratio of 0.56, which attributes to a 43.2% reduction in the risk of progression. And more importantly, I want to point out the separation of the curves is quite early. If you can see in this particular chart, that the curves, they are separating as early as 8 weeks with Crixana as compared to the control arm. And if you see the waterfall chart, that 3 out of 4 patients who are using this combination, they saw a reduction in the tumor size as early as 8 weeks. So this brings in a very important debate that whether in visceral crisis can we use CDK inhibitor or not. A very good scoring system with made by ESMO, that is MCBS score, that is magnitude of clinical benefit score. And if we see this particular score, that is either 4 or 5, which is considered to be having a good clinical benefit. So this scoring system tells us about a good, the clinical value, the clinical benefit of a particular trial, which is very well, the score is very well noted down in Crixana. So that was all about Mona Lisa 2. Now, if you see Mona Lisa 3, that is Crixana with fulvestrant, and if we see the overall survival curves in the entire population, the median OS was 53.7 month, nearly 4.5 year median OS versus 41.5 months. And if we see the subgroup having received ribociclib plus fulvestrant in the first line setting, the median overall survival has not been reached versus 51.8 months. We can see the beautiful separation of the curves. And if we see the subgroup of the patients having liver metastasis, in this particular subgroup, the median OS with the combination of Crixana fulvestrant was 36.1 month versus 24.1 month, with 37% reduction in the risk of death. Time to chemotherapy, again, it was delayed by about 4 years, median 48.1 month versus 28.8 months. Again, the reduction in the tumor size was noted very early. 2 out of 3 patients with Crixana fulvestrant saw a reduction in the tumor size at 8 weeks. Forest chart, nearly all the subgroups, they showed benefit with the combination. Now, regarding Mona Lisa 7 study. So premenopausal women with advanced breast cancer, they have a distinct clinical as well as emotional needs. And we all know that diagnosis at a young age imparts a bad biology, and it is associated with a higher risk of relapse as well as death. And it has been seen that among patients with hormone positive disease, the risk of death is up to twice greater in younger patients. And the quality of life is adversely affected. So if we see the Mona Lisa 7 overall survival curves, the median OS in this study was 58.7 months versus 48 months, nearly 5-year median OS with Crixana plus AI. And the subgroup of liver mets, a very wide separation of the curves, median OS not yet reached versus 33.6 months with 47% reduction in the risk of death. If you see the endpoint of time to chemotherapy, again, a wide separation of the curves, median 50.9 versus 36.8, time to chemotherapy delayed by over 4 years with 30% reduction in the risk of progression to next line of chemotherapy. The quality of life data, TTD, this time to deterioration curves, if we see that the curves, they are very well separated with the median time to deterioration of 34.2 months versus 23.3 months. So fairly, the quality of life is well preserved with this combination. Again, the reduction in the tumor size noted as early as 8 weeks. 3 out of 4 patients, they show a reduction at 8 weeks, which is consistent with the previous mentioned trials. Again, all the subgroups, they derive benefit of this particular trial. So to summarize that, our main three important aims of any MBC patient, that is to live longer, to make our patients live well with a good quality of life, and to make them live longer without chemotherapy. All these three important aims are very well fulfilled with Rexana. As noted, we have a nearly 4.5-year median overall survival in first line and second line postmenopausal patients in the entire subgroup that was in Mona Lisa 3 with Rexana and fulvestrant. And at 5 years, more than half of the first line postmenopausal patients were alive with Rexana plus fulvestrant, and nearly 5 years median overall survival in first line premenopausal patients with Rexana plus AI. With this, I thank the organizers for giving me this opportunity. Thank you.
Thank you, sir. Thank you for the nice presentation. Next, we move on to the next presentation, Picking the Right Strategy in Management of HR Positive, HER2 Negative ABC. And this talk will be given by Dr. Varun Goyal, who is Consultant Medical Oncologist, RGCI Delhi. Over to you, sir.
So my slides are visible?
Yes, sir.
Yeah. So thank you, Dr. Kumadi, for giving this opportunity today. And topic given to me is to discuss role of PIK3CA target therapy in these PIK3CA mutated hormone receptor positive HER2 negative advanced breast cancer patients. And mainly in this study named SOLAR-1, they have analyzed patient-reported outcomes in these patients. So to start my presentation, first of all, I want to share this study. So this study was published in 2017, and in which they have analyzed about the pain and quality of life in breast cancer patients. So overall, 400 patients they have taken. It was a cross-sectional study, and they have concluded that pain compromises the quality of life of patients with breast cancer, particularly those with advanced stage of the disease. So it seems very logical, but we have to look for that to achieve that goal also, so that we should improve quality of life for patients, mainly in advanced setting. So patients with breast cancer often experience chronic pain, fatigue, and impaired quality of life. So what about these hormone receptor positive HER2 negative breast cancer subtype? How common is this? So it comprises over 70% of all breast cancer cases. So this is more common one type, like hormone receptor positive HER2 negative. And health-related quality of life is an important factor in assessing the risk-benefit profile of the treatment. In this study, SOLAR-1, they tried to evaluate the combination of alpelisib with fulvestrant on this quality of life issue in patients with PIK3CA mutant, hormone receptor positive, HER2 negative advanced breast cancer. And the strategy of adding these targeted therapies to endocrine therapy before initiating chemotherapy implies that these treatments maintain quality of life. So what usually happens, as Dr. Chitish have already discussed, that in hormone receptor positive HER2 negative patients, advanced breast cancer patients, we should go for Rexana, like ribociclib. But if patients progress on that, because there is one resistance mechanism of this PIK3, if PIK3C mutation is there, then patients usually progress on Rexana. Then in those patients, next option usually we had chemotherapy. But chemotherapy is involved with different chemotherapy-induced side effects, and that hampers quality of life. So that's the main logic. So that if we can add one other target therapy to these endocrine therapy to counter this resistance mechanism, and so that we can delay chemotherapy use and we can improve quality of life on patients. So what is the importance of this PIK3A pathway, PI3K pathway in these hormone receptor breast cancer patients? So this PI3K mTOR pathway is usually frequently altered in these hormone receptor positive breast cancer, and has been shown in different studies that it is implicated in resistance to endocrine therapies. So 40% of the hormone receptor breast cancer, hormone receptor positive breast cancer harbor a PIK3CA mutation. So before this mutation and before this availability of this drug, what we usually do to counter this hormone receptor resistance, so we had added mTOR inhibitors as per Bolero 1-2 trials. But there was side effect profile of the everolimus. It was the problem. and most of the time we couldn't give that drug in full dose. But now with this further understanding of this pathway and with this PIK3CA targeted therapy availability, so now we have this drug Pluvicto, that is alpelisib. So 40% of the hormone receptor positive breast cancer harbor PIK3CA mutation and leading to hyperactivation of the PIK3 pathway, PI3K pathway. So this PI3K signaling promotes estrogen independent growth of hormone receptor positive breast cancer cells, and this growth is inhibited by the addition of PIK3 inhibitor to anti-estrogens. So that was the concept, and why we should add this PIK3 targeted therapy to endocrine therapy. So what happens if we selectively inhibit PI3K alpha isoform? So it is a promising strategy in these PIK3CA mutated cancers. So while pan PI3K and beta sparing PI3K inhibitors target multiple PI3K isoforms, but alpelisib specifically target PI3K alpha isoform. So there are 4 types of PI3K isoform: alpha, beta, gamma, delta, out of which alpha isoform is the one which is targeted by alpelisib, and alpelisib has demonstrated anti-tumor activity in preclinical models with PI3CA alterations, and in a phase 1b trial, median PFS with alpelisib plus fulvestrant has been reported 9.1 months in heavily pretreated patients in these advanced breast cancer who are hormone receptor positive and PIK3CA mutation was there. So we very clearly can say that with the addition of this another targeted tablet drug, further 9 months PFS improvement is there, and so chemotherapy can be delayed further by 9 months at least. So we will discuss about this SOLAR study, that was landmark trial regarding this alpelisib, and based on which this drug have got approval and has been have come in different guidelines also. So SOLAR 1 is alpelisib plus fulvestrant versus placebo plus fulvestrant. So in this study, alpelisib fulvestrant have been compared with fulvestrant alone in these hormone receptor positive HER2 negative advanced breast cancer. So study schema was that men or postmenopausal women with these hormone receptor positive HER2 negative advanced breast cancer patients who had recurred on or after prior AI. So measurable disease should be there, ECOG performance status should be 0 or 1. Then they have stratified all those patients according to whether those patients have already received CDK4/6 inhibitor therapy previously or not, and whether there are liver, lung metastasis or burden of disease. So then they have all the patients have been randomized in 1:1. Overall, 572 patients have taken, and half the patients who are PIK3CA mutant cohort, and another half of the patient are PIK3CA non-mutant cohort. So in mutant cohort, alpelisib plus fulvestrant was given in half the patient, in around 170 patient, and around 170 patient placebo plus fulvestrant. And similarly, in non-mutant PIK3CA cohort, same half the patient, 115 alpelisib plus fulvestrant and 115 placebo plus fulvestrant. So overall, there are 4 arms. 2 arms, 340 patient with PIK3CA mutation, rest 230 patient without PIK3 mutation, and half of patient have been given alpelisib versus placebo. Primary endpoint for this study, they have taken PFS in all the patients who have randomized, mainly in PIK3CA mutant cohort. And second endpoint, overall survival in this PIK3CA mutant cohort, and PFS in non-mutant cohort, and otherwise overall response rate and quality of life. So PFS in these PIK3CA mutant cohort, we can see in this Kaplan-Meier plot that median PFS with alpelisib plus fulvestrant is 11 months versus placebo plus fulvestrant, or I may say fulvestrant alone, is 5.7 months. So there is stark difference, almost doubling of the PFS. P-value is statistically significant, and we can be very clearly we can see that both the lines are separated from each other from the very beginning, from the 1 month after the 1 month only, and have been separated till the follow-up of around 2.5 years. And so mutation status they have taken from the tissue, from the archival biopsy. Similar results with mutation status have been seen if they have taken tissue as circulating tumor DNA, and only 6% of the patient prior CDK4/6 inhibitor exposure was there. So nowadays, any new advanced patient, advanced cancer of breast cancer, we usually start with the CDK4/6 inhibitor. So, and after that only, if patient progress on that, we search for this PIK3 mutation, and then we go ahead with this Pluvicto. But in this SOLAR-1 study, only 6% patients have been already been given CDK4/6 inhibitor. So, what I want to emphasize here that it's not necessary that this NGS and these PIK3 mutation testing should be done or can be done only if patient progress on CDK4/6. We can very well order for this mutation upfront also. And if patient is already PIK3 mutation positive, then we can give this drug even in first line, even before CDK4/6 inhibitor, if patient had progressed on hormone therapy. So about adverse event, with Elpaslib and Fulvestrant, there are around 63% all grade, almost all patients have some grade of side effect, but grade 3-4 side effect have been seen in 64% and 11%. While on the other hand, only Fulvestrant injection, we all know that there is no much side effect, and only grade 3 side effect were in 30% patient, and grade 4 in only 5% patient. So what was the common side effect with the addition of this Elpaslib? So most common side effect which we should aware of and we should monitor during the treatment is hyperglycemia. So hyperglycemia is the one which may because of which we if we don't monitor that, we may have to discontinue the drug because of this hyperglycemia and related complication. So up to 32% patients have been seen grade 3 hyperglycemia and around 4% grade 4 hyperglycemia. Rest all the side effect maybe some grade 3, otherwise most of the time grade 1 or 2 side effect. No grade 4 side effect have been seen beside hyperglycemia. Some diarrhea, nausea, and rash, vomiting may also be seen with in grade 3 with Elpaslib, but otherwise most of the time grade 1 or 2. Rest all side effects are very well manageable, and because of all other side effects, there is no need to discontinuation of the therapy. And this hyperglycemia also we can very well manage, but if we look for that and if we are aware of that. So 25% of the patient discontinued Elpaslib, out of which 18 patients have discontinued because of hyperglycemia, 9 patients because of rash, and no patient discontinued placebo due to either of these side effects. So rash type was maculopapular, all grade, including grade 3 side effects have been seen in around 14% patient with Elpaslib versus 1.7% with placebo. So I started my presentation that I'm going to discuss about the patient outcome. So what about that? So patient outcome assessment have been done by EORTC and brief pain inventory measures. So patient use past week data of assessment for item in EORTC quality of life C30 version, and for brief pain inventory, patient use past 24-hour data for assessment of items in brief pain inventory short form. Based on this, it has been shown in this study that global health status, quality of life, and functional status were maintained from baseline in the Elpaslib group, and overall change from baseline is minus 3.5 only, versus placebo group, where overall change is 0.27. So in the quality of life measures with the use of Elpaslib, there is slightly betterment, but no deterioration. There is no difference in the overall adjusted mean changes from baseline in functioning subscale score if we talk about the pain and other side effects. So time to treatment discontinuation analysis were also consistent with the observed mean changes and did not demonstrate differences between the two treatment arms. So what I want to emphasize here that there is significant improvement in the PFS, there is significant improvement in the quality of life, as such there is no deterioration. So like there may be some debate that if Fulvestrant alone we can give, and later on progression we can try some another hormone treatment, but that was the dictum like few years back. But if we add Pluvicto, so there is improvement in the PFS, but then a debate is that whether if it is on the basis of some side effect, significant side effect, then what the point? But so that's the reason we want to see show here that there is no deterioration of the quality of life. Most of the side effects are grade 1 or 2, very well manageable, and there is no treatment time to if even time to treatment discontinuation also is not different in these two treatment arms, Elpaslib versus placebo, like Fulvestrant. So Physical and emotional functioning subscale also favors LP-SLIP arm, although both of these we can very well see here that crossing midline, but still slightly favoring LP-SLIP. So TDD analysis of functional scales showed no statistical difference in these, either of physical or emotional or social functioning subscale scores. Other side effect profile like constipation score, it has shown improvement in the LP-SLIP arm. There is numerical worsening of the pain in the placebo arm, although not much different. So worst pain items and pain severity index suggested that a delay in the worsening of pain and pain severity in LP-SLIP treatment arm as compared to placebo treatment arm. So most of the time, these hormone receptor positive advanced breast cancer patients have multiple bony mets, and there may be some like significant pain in most of the patients. So if we use this drug with fulvestrant, it has been shown clearly that this worsening of pain and pain severity has been delayed and has been decreased with the use of this drug. So at week 24, higher numerical improvement and lower numerical worsening in worst pain were observed in the LP-SLIP treatment arm, and were similar numerical changes observed at week 8 and week 16. So with this, overall, the investigators have concluded that in this SOLAR-1 study, there was no statistical difference in deterioration of the quality of life and quality health status points between these two arms if we compare LP-SLIP with fulvestrant versus fulvestrant alone. Physical, emotional, cognitive, and role functioning scores. So they try to evaluate all the parameters of this quality of life with the URTC and pain measures. And in all these scores, they were similar to those observed in the placebo group. Clinical decisions must consider efficacy and tolerability taken with clinical efficacy. These results support the benefit risk profile along with the statistically significant and clinically meaningful PFS observed with the addition of LP-SLIP to fulvestrant. In these hormone receptor positive, HER2 negative, and PIK3CA mutated advanced breast cancer patients. So with this, thank you for to the organization and.
Thank you, sir. Thank you, Varun Goyal, sir. Next, we move on to the next topic. And for this, I would like to invite Dr. Atul Sharma, who is Executive Consultant, JP Hospital, Noida. And he's going to talk on 2 centimeter and beyond redefining treatment landscape in HER2 positive EBC. Over to you, Atul, sir.
Good evening, everybody. Is my screen is visible?
No, sir, not yet.
Is it visible?
Yes, sir. Now it is visible. Just make it a full screen.
Yes.
Yeah.
A very good evening to everybody. So today the topic is to understand the management of the breast cancer with particularly emphasis on the HER2 positive with the lesion more than 2 centimeter. So 2 centimeter and beyond, the changing landscape or the redefining treatment landscape in HER2 positive early breast cancer. So we know that there is a significant burden of breast cancer as such, and according to the subtypes, we can see that there are 2 charts in front of us. One is between the hazard ratio of relapse in patients with biopsy proven stage 1 to 3 breast cancer from a time period of 1986 to 1992 on my left, and on the right side 2004 to 2008. So the arrow is pointing towards the curve, which is showing the relapse rate of the HER2 positive breast cancer. So we can see there is a decline in the trend of recurrence of the HER2 positive breast cancer, and this has predominantly because of the HER2 directed therapies, and among this particularly the trastuzumab. So same what I discussed in the previous slides, that focused adjuvant trastuzumab studies has led to the improvement in the outcomes. Trastuzumab offers survival to the tune of around 9% in adjuvant setting, and this is how we divide the early stage and the locally advanced stage. what are the expected benefits when we offer somebody a new adjuvant systemic therapy as compared to the adjuvant chemotherapy. It facilitates breast conservation, can render some inoperable to operable, and it imparts a prognostic information. I think this is very important because we tailor our therapy depending on whether we have achieved a pathological CR or whether there is any residual disease. So we can modify, we can add some drugs, we can upgrade, we can change, and it allows time for genetic testing, but we are usually not much keen for, particularly in the case of HER2 positive, but in triple negative, we do keen for genetic testing. And then we divide locally advanced into inoperable and operable, inflammatory, bulky, matted N2, N3 nodal, and few at T4 tumors are inoperable. The rest all we usually say they are the operable tumors. So systemic therapy, same indication that we have discussed, sometimes high tumor volume to breast ratio, lymph node positive disease, high risk features such as triple negative, HER2 positive, and those lesions who are usually more than 2 centimeters, we usually advise neoadjuvant chemotherapy, particularly in the node positive. Chemotherapy plus trastuzumab or either, plus minus pertuzumab. So these are few trials which have explored the neoadjuvant chemotherapy regimes, usually conventional drugs, anthracycline, taxanes, and cyclophosphamide. So there are two trials which are actually phase 2 trials which have specifically explored the role of neoadjuvant chemotherapy. They used pertuzumab, and one is the Neosphere and the Trifina. In the Neosphere, they included they assessed the response rate, pathological CR, after the using the combination of docetaxel, pertuzumab, and trastuzumab, and the highest path CR rates were achieved in this arm as compared to the other arms. So these are the path CRs in the arm A, B, C, and we can see that this is the 3-year follow-up. We can see that the event-free survivals and overall survivals are usually correlating. Few points to consider, though we are discussing here HER2 positive, but meanwhile, when we use HER2 positive neoadjuvant chemotherapy regimes for HER2 positive disease, we do try to get away with the anthracyclines, and there is definitely some evidence that we can get away with the use of anthracyclines, particularly in low risk HER2 positive tumors. So these are the newer developments with the use of TDM1. Those we can use them in case we have residual disease post neoadjuvant chemotherapy. If we have done upfront surgery, we can use trastuzumab, pertuzumab, and in case of we have used only trastuzumab, we can use niraparib. The issue with niraparib is it is not available in our country. This is the drug TDM1. So from the phase 3 trial Catherine study, so there is evidence that it offers invasive disease-free survival benefit in particularly those tumors who have residual disease post neoadjuvant chemotherapy. We can see there was almost 10% difference in the invasive disease survival. And if we try to explore the distance recurrence, again, there was around 5% survival benefit. In 5% benefit in invasive disease-free survival. So we can see all the subgroups are usually showing benefit, but a subgroup which was smaller, around 18 to 20%, which received dual neoadjuvant chemotherapy, maybe not showing much benefit, but maybe because of the lesser number. So there is an exploratory analysis that they try to answer that even if you have received pertuzumab in the neoadjuvant setting, still TDM1 in adjuvant can offer you invasive disease-free survival benefit. But there are limitations such as exploratory analysis and a smaller sample size. These are the usual adverse effects. I think thrombocytopenia is a significant side effect with trans TDM1 when we use it for longer durations. Also derangement in liver function test, rest, fatigue, and these are the common side effects. This is another strategy, niraparib, which can be used if we have not used TDM1, and The issue is that it is not available in our country. Otherwise, it is also offering invasive disease-free survival benefit over and above the use of trastuzumab in the adjuvant setting. So these are, they have then done subgroup analysis with hormone positive disease, hormone negative disease, those who started less than 1 year. And this is a proposed management according to what we have discussed. So our focus was on the right side with 2 centimeter and beyond. We can use neoadjuvant chemotherapy with or without pertuzumab, with or without anthracycline. If we have residual disease, we can use TDM1. If we don't have residual disease and hormone positive disease, we can consider for niraparib. So there is one cost-effective analysis also published, and as per this, we can use the strategy 3 THP, where residual disease we can upgrade the treatment to the dose then AC or TDM1, or if there is PATH-CR, we can use only trastuzumab. Though I have not gone into the details of this analysis. So we have TDM1 biosimilar available in our country, which is cheaper as compared to the original product. We do have a phase 3 study. We have data for its efficacy as well as toxicity, which was published in last year only. Thank you. So I think with this I end my talk, and the takeaway point is that after the neoadjuvant chemotherapy with residual disease, we can explore the options of adjuvant TDM1 in those where, and I think we are already using this in our practice. And with the advent of the biosimilar in our country, the cost has gone further.
Thank you so much, sir, for your excellent talk. We'll move forward for the next session. For next session, I would like to invite Dr. Saifali Shardana ma'am, Senior Consultant Medical Oncologist, Max Super Specialty Hospital, Delhi. Over to you, ma'am.
Yeah, hi, just give me 2 minutes. So I have just network issue. I'll be logging out and then logging in, just 2 minutes only. Yeah, hi, good evening. So just sharing my screen. Yeah, just once. Yeah, is my screen visible? Just, yeah, is my screen visible?
Yes, ma'am.
Yes,
Yes,
ma'am.
ma'am. Perfect.
Yes, yes.
Yeah, sure. So good evening, everyone, and sorry for the just on the spot glitch. So I will be discussing about durvalumab in stage 3 non-small cell lung cancer. It's a AstraZeneca sponsored session. My slides are provided by AstraZeneca only. This is my disclaimer. And we'll be discussing basically the context and background behind the durvalumab, its prelim results, and now updated OS data, 5 years updated overall survival data. So as you all know that there is increasing burden of lung cancer also in our country, in India. So, and it's the second most common cause of cancer related deaths in our country, apart for the new cases. And uh, and out of the context, out of the population where we talk about lung cancer treatment, so stage 3 lung cancer management, that to non-small cell lung cancer, is somewhat more debated, because earlier staging system used to classify tumors more than 7 centimeter as more than 5 centimeter as or T3N1 as stage 3. But now the current classification includes, if the tumor is more than 5 centimeter, there should be inclusion of mediastinal node to classify as stage 3, or more than 7 centimeter with or without the mediastinal lymph nodes. And management of stage 3 lung cancer actually depend upon the bulky and non-bulky disease, because if we classify unresectable stage 3, so it should include a bulky N2 or N3 disease, for which we will be talking about. So, management of unresectable stage 3 non-small cell lung cancer actually includes a multidisciplinary team, because many of the trials have been done, and most favor the concurrent chemoradiation as the standard of care. Some trials also have tested neoadjuvant chemotherapy followed by chemoradiation. Some include neoadjuvant chemoradiation followed by the surgical option also. So, having said that, highlighting the importance of multidisciplinary team management to decide for resectability, and if it is unresectable, then what should be the next approach. So all team approach, pathologist, radiation oncologist, medical oncologist, pulmonologist, and thoracic surgeon are required. And we know that FDG PET scan plays very important role in staging evaluation, as well as the proper mediastinal lymph node evaluation by EBUS plus PET CT versus mediastinoscopy, that has been much debated. Then general health of the patient, considering lung status, also determined by pulmonary function tests and bronchoscopy, and evaluation of brain in all T1B and above cases by brain MRI with contrast. So once we label somebody as unresectable stage 3 after a tumor board meeting, then the standard approach for those patients is definitive chemoradiation. So again, so many aspects of chemoradiation has been studied in trials. So people have used concurrent regimens, people have used sequential regimens, and be it concurrent or sequential, the platinum-based treatment is the standard of care. People have used cisplatin etoposide as the concurrent regimen, cispem, cisvinblastin, then carbopecli, and none of these regimens or none of these concurrent chemoradiation strategies has shown a median PFS beyond 10 months actually. So there is a highly unmet need to prolong PFS, and for that matter overall survival in such subgroup. Even if you see the sequential regimens, full dose chemotherapy used along with the this radiation, so none of them has achieved reasonably good response rate or PFS rates along with any of these concurrent chemoradiation. So as I talked about, there is unmet need in stage 3 non-small cell lung cancer to extend the PFS and for that matter OS. So people have tried various approaches. because more than 40% of these patients after concurrent chemoradiation do have a progression in locoregional metastasis, and I mean quite a big chunk of 50% has a distant metastasis. So till the consolidation approach was studied, the median PFS was reported to as 8 to 12 months, and 5-year overall survival was 15 to 25%, which was dismal in stage 3. So then there were various trials which were conducted to see the role of adjuvant or a consolidation type of chemotherapy, or for that matter, any other vaccines or targeted therapy which could extend the overall survival. So in this context, people have tried docetaxel for 3 to 4 cycles, and gefitinib also, docetaxel plus carboplatin, and other targeted vaccines type of treatment. But none of these again showed a statistically significant improvement in PFS as well as OS, and the PFS still remained 9 to 10 months in such patients. So none of these phase 3 studies consolidation have demonstrated any advantage. So if we see how the treatment strategies in stage 3 non-small cell lung cancer evolved, so the history dates back to 1967. Once, most of the people were using radiotherapy only in stage 3 lung cancer, and then it was compared with sequential chemoradiation, and it showed a median overall survival of 13.8 months versus 9.7 months in the radiation alone arm. And then coming to in late 90s and early 2000s, so 1992 to 2006 era, so concurrent chemoradiation was compared with RT alone, and there was a OS benefit 16 versus 2%, and survival gain of 10 months was seen. So then concurrent chemoradiation became a standard of care, and it was again compared with sequential chemoradiation, where concurrent chemoradiation showed an advantage as compared to sequential. And then there came the trials of induction chemoradiation versus concurrent chemoradiation alone, and superiority of concurrent chemoradiation was a gray zone or controversial area. So having said that, management of lung cancer, and that too locally advanced unresectable, has been evolved over an era of so many years, and with people trying various permutation and combination with platinum-based chemotherapy or chemoradiation for that matter as a baseline standard of care, but none of these approaches has succeeded in providing a meaningful overall survival benefit. So with all of these trials, so it was concluded that concurrent chemoradiation till the time was standard of care, and till this time is standard of care to begin with in good performance status patients, and where we cannot utilize this concurrent chemoradiation, so the sequential chemoradiation remains an option for the marginal performance status. And to improve further prognosis, strategies like radiation doses, induction chemo, consolidation chemo, all have been tried, but no significant meaningful improvement in survival. So now the era of immunotherapy comes actually, and immunotherapy was tried in the neoadjuvant settings, in the consolidation setting, in the metastatic setting, wherever. And honestly, I think that immunotherapy is the drug which has made a real difference in the management of non-small cell lung cancer. So the Pacific study actually evaluated role of one of such kinds of immunotherapies, durvalumab, in consolidation setting after concurrent chemoradiation in unresectable, locally advanced non-small cell lung cancer. So it was a phase 3 randomized, double-blind, placebo-controlled, multi-center international study, and patient basically with stage 3 locally advanced unresectable who haven't progressed following definitive platinum-based concurrent chemoradiation, at least 2 cycles, because the regimen was not fixed whether it was platinum etoposide or carbopacli for that matter. So at least 2 cycles were permitted. So and the patients who responded or not progressed following definitive platinum-based chemoradiation were allowed to enter in the trial, and they had a performance status score of ECOG 0 or 1, and estimated life expectancy of more than equal to 12 weeks means no generalized such comorbidity which could be detrimental. and they were in good health. And they were randomized in 1 to 42 days post concurrent chemoradiation to durvalumab versus placebo arm. So it was a 2:1 randomization, and they were further stratified by age, sex, and smoking history. So co-primary endpoints were PFS by blinded independent central review and OS, and secondary endpoints were overall response rate, duration of response, safety, and tolerability. So if you see the baseline characteristics, I think they were reasonably matched as per the randomization. All have good representation. However, so male were more representative in that based on probably by the smoking history, or then all of the I think Asian population was, yes, 25% in this study, and precisely stage 3A and 3B population was included. And EGFR mutation status was negative or unknown in approximately a major chunk of the patient, that is approximately 80% to 90%. And only 6% were EGFR positive, which were included in this study. And if you see the other baseline characteristic, the further studies or analysis was done on the basis of PD-L1 expression, tumor cell score less than 25 versus more than 25%. And both squamous and non-squamous histologies were equally represented in this trial. And almost 74% or 74% were former smoker and 16 were current smoker also. So as we know that immunotherapy works more in patients who are actually former smokers or current smoking. So this study also tried to highlight that point. And induction chemotherapy actually was used in 25% of the patients, while concurrent chemo was used along with radiation in approximately major chunk of the patients. So if we see that in Pacific study, prior chemo radiation at baseline, like we saw the eligibility criteria, so all patients received 2 or more overlapping cycles of platinum-based chemotherapy concurrent with radiation, and patients who had received induction chemotherapy or prior chemotherapy were also allowed in this study. So now we know that the interim analysis or the preliminary analysis of this data had showed that it already crossed the pre-specified PFS margin, and the median PFS was reported as 16.8 months as compared to 5.6 months in the placebo arm. So that is absolute 10 or 11 months of advantage in terms of PFS. So if we see this now updated 5-year overall survival analysis in intention to treat population, so you can see a 47.5 months of median OS in durvalumab arm as compared to 29.1 months in the placebo arm. So wonderful stratified hazard ratio of 0.72. So this is the first and only approved immune checkpoint inhibitor to demonstrate 42.9% overall survival at 5 years. So a figure which we could only see in metastatic settings, sometimes in the driver mutation positive patient. So in unresectable stage 3 patients, where for so many years that we were looking forward to a OS of only 10 to 15%. And this now 42.9% at 5 years is a wonderful revolution, I think. And now if you see a updated PFS by blinded independent central review, so this drug again showed a consistent PFS benefit of 16.9 months as compared to 5.6 months with a impressive hazard ratio of 0.55. So this is again first and only approved IO to show a sustained and durable PFS of 33.1% at 5 years. So if you see further analysis, so in durvalumab arm, 41% of the patients received actually a subsequent disease-related anti-cancer therapy when they progressed, and systemic therapies were the most common first subsequent anti-cancer treatment in both of the arms. And in terms of the patterns of disease progression, so it was seen that there were reduced rates of first progression, which were seen in the durvalumab arm as compared to placebo arm. And intrathoracic progression was most common as compared to systemic progression in the placebo arm. And this graph again shows that time to intrathoracic progression by the blinded independent central review, it was 25.2 months as compared to 9.2 months in placebo arm. So graphs are still separating. And there were reduction in the new extrathoracic lesions in the durvalumab arm, that is 8.8% at first progression versus 16.5% for the intention to treat population. Again, so in durvalumab arm, there were the progression was mostly in terms of the intrathoracic and locoregional progression as compared to the systemic or distant progression in the placebo arm. And approximately 2/3 of the patients had 1 or 2 extrathoracic lesion at first progression in subpopulation with progression. And if you see the safety and tolerability data, I think we know that the immunotherapies for that matter, even in the metastatic setting, even in any setting, so the all grade 3-4 events are to the tune of say 10 to 11%. That is same with durvalumab also. And any grade pneumonitis was 33.9% in the durvalumab arm as compared to 24.8% in placebo arm. So again, well tolerated as compared to any type of chemotherapy, or for that matter, compared to the placebo arm. So if we see that the safety of durvalumab, if we choose the timeline when it was started, so we can see any grade pneumonitis or radiation, for that matter, radiation pneumonitis was 39.2% in the durvalumab arm when it was started less than 14 days as compared to 16.7 in the placebo arm. And when it was started in more than 14 days, so it was 32.1% as compared to 27.6% in the placebo arm. So numerically little more. And we know that post radiation, because most of these patients have underlying lung changes, most of these patients have COPD changes or ILD changes. So for that matter, I mean, reasonably expected. So if we see the real life data on durvalumab, so because we are very particular about starting durvalumab within 1 to 42 days after completion of chemo radiation. So if we see the real life data, which was assessed actually in this analysis of 591 patients which were enrolled in French cohort temporary authorization for use assessment, and actually this assessment, what it did was, so 498 new patients were granted approval for this assessment out of the 643 which requested, and out of these 591 were granted the approval, and 27 patients never ordered the drug, and 3 patients were never treated. So of the 591, so eligibility criteria was almost same as the primary trial. However, the patients with unresectable stage 3 and with no possibility to enter an ongoing clinical trial were included, and major exclusion were unresolved grade 3 or 4 toxicity 6 weeks after CCRT, or grade 2 pneumonitis 6 weeks after CCRT, prior immunotherapy or prior immune syndrome history in past 2 years. And again, I mean, if you see the histology, all adeno, squamous, large cell, they were all enrolled. And I mean, all these assessment also included stage 2B patients, but representation was very less, more or less 3 and 3B. And EGFR, again, less population, but they were included. And if we see at the end of concurrent chemoradiation, when the response was evaluated, almost 78.5% had partial response, 15.2% has stable disease, and 6.3 had CR also. And median interval between end of concurrent chemoradiation and effective initiation of durvalumab was known for 161 patients. And out of these 161, 64 patients were there where they started durvalumab more than 42 days after concurrent chemoradiation. So almost 40% patients who started durvalumab more than 42 days of completion of concurrent chemoradiation had also significant response. So we try to accommodate patients within the trial limits, but however, if some patient has response or for that matter stable disease after concurrent chemoradiation, and for some reason if we are not able to enroll them into or make them eligible into this consolidation treatment, so this is not like that we cannot do it beyond 42 days after having this assessment. So as of September 2019, so this assessment 360 patient data is available, and the responses were Same if we started, say, within 42 days versus some patients, 40% which started after 42 days of concurrent chemoradiation. So I think there is definitely hope for cure in stage 3 non-small cell lung cancer, seeing that consolidation data, because 5-year survival is important endpoint, and optimal CTRT followed by a response. Immune checkpoint inhibitors should be the standard of care in all stage 3 unresectable patients. And I think it's a good thing that converting stage 3 lung cancer into never progressing stage, I think that's something which is really commendable. So my takeaways are durvalumab demonstrated a statistically significant and clinically meaningful improvement in overall survival and PFS versus placebo in Pacific trial. The median OS was 47.5 months for Durva versus 29.1 months for placebo, and hazard ratio was 0.68. Median PFS 16.9 months versus 5.6 months in placebo, and again impressive hazard ratio of 0.51. So there was OFS and PFS improvement, which was demonstrated across all pre-specified subgroup, which was durable, which is consistent after the updated 5-year data also. So I thank you and I rest my talk here. Thank you so much.
Thank you, ma'am. Thank you so much for the excellent presentation. Next, we move on to the case-based discussion on optimal management of ES, SCLC. And for this, I would like to invite our moderator today, Dr. Nagendra Sharma, Consultant Medical Oncologist, Medanta Hospital, Gurgaon. Over to you, sir.
Thank you. Thank you very much for kind introduction. So whether my slides are visible? Can you stop sharing, Dr. Shefali? You are not audible.
Yeah, I have stopped sharing actually. Your screen
Yes,
is visible. Yeah.
We can see your desktop. Just open your PPT.
Right. Okay. Right now, whether it's visible and audible, this is the most common question
Yes,
which is asked is during webinar,
Yes,
whether
yes.
my slides are visible and whether my voice is audible. Okay, so within the limitation of time, so we are coming toward the end of this presentation. I'll be very quick to invite my panelists. So I think all of us are here. So my panelists before starting this panel discussion. So Dr. Mukesh Patekar, are you there, sir?
Dr. Mukesh, I haven't joined.
Okay. Dr. Pankaj Goel, sir?
Yeah.
Yes.
Okay. Dr. Shaina Goel? Dr. Shaina, are you there? I don't think she's there. Okay. Dr. Varun is there, I can see.
Yes.
And Dr. Tanvi Sood?
Hello, yeah, I am here.
Okay. Dr. Praveen Jain, sir?
Yes, I'm here, Nagin.
Okay, sir. Thank you. Thank you very much, sir, for coming to this panel discussion. So we are having a esteemed panelist here. So I'll be quickly moving towards the case presentation. So, today's presentation is on optimal management of extensive stage small cell carcinoma lung. It will be a case-based discussion, and I'll be very, very sharp in my questions. So I will be requiring any precise answers. So 62-year-old gentleman who's a current smoker for 35 years, presented with the complaints of shortness of breath, hemoptysis, weight loss, and early satiety. On examination, patient was found to have a massive liver enlargement on physical examination, and on laboratory workup, the alkaline phosphatase like AST, SGPT, SGOT are 3 times the upper limit of normal. A CT imaging was done for this patient, and CT scan have shown that there is a left lower lobe nodule, mediastinal adenopathy, and a massive hepatomegaly. So biopsy was contemplated, and the histopathology report came out to be small cell lung cancer. So can I ask Dr. Pankaj Goel, sir? So this is the scenario. So how will you proceed? How will you evaluate further this patient? Is a biopsy-proven small cell carcinoma lung? Dr. Pankaj, sir.
So I think PET scan is very much. Hello?
Yes, sir. You're audible, sir.
Yeah. So I think in small cell lung cancer, the diagnostic imaging standard of care remains a PET scan and a MRI imaging irrespective of the symptoms. So, and along with the histopathological diagnosis, along with the IC, we also need to have the the PD-L1 status of the patient. And the performance status, as you were saying, is performance status 1, I suppose, right?
Right.
And
right.
so all these things are required to plan the further treatment.
Fair enough. So may I ask Dr. Varun sir, like how many patients in your clinical practice will be diagnosed as limited stage small cell carcinoma lung, and how many of them will be extensive stage carcinoma lung? Or is there anything known as very limited carcinoma lung, like very limited stage also? Can you define that?
So most of the time it is extensive stage lung disease only. So at diagnosis, I may say like 80-85% are extensive stage only. Rest are limited, and very limited is very rare for at time of diagnosis, like maybe 1 or 2%, but still most of the time 10-15% limited, otherwise extensive.
Absolutely right. So your answer is absolutely correct. May I ask Dr. Praveen Jain sir, your take, like in your practice, how many patients of your practice in small cell carcinoma lung will be limited stage, and how many of them will be extensive stage?
So I think what I have seen is almost 30% of them, they are limited stage, and 70% approximately are extensive stage.
Right. So by and large, you are all of us, I think we are in consensus that what I remember is 1/4 of the patient will be limited stage, and remaining 3/4 of the patients will be extensive stage. By and large, this is a ballpark figure you can remember. So in this patient, as Dr. Pankaj Goyal sir have told that obviously we have to do guide biopsy, and if biopsy is small cell carcinoma lung, we have to do IHC markers, and along with that we will do Ki-67 and further staging, that is MRI brain. Suppose the patient is in a poor performance status in ICU and MRI is not possible, will you be happy to go ahead with a non-contrast CT scan, which can be done inside ICU only, or you are always on for contrast enhanced MRI brain, sir? Pankaj Goyal sir.
Sir, I think if situation is such that you cannot go ahead with imaging of that is MRI, then I think CT is good enough. We need not break our head key. Even if there are very small metastases, then probably they are not very significant. They can be addressed later on. And anyway, if the condition is so bad because of the systemic disease, anyway, we'll be offering chemotherapy first. So I think case to case basis, we can change our plan.
Absolutely right. I do agree. So may I ask Dr. Tanvi Sood, so is this the report of small cell carcinoma lung with Ki-67 is sufficient enough for you to start treatment, or you will be happy to do some molecular markers to take the case forward?
So, sir, if it is a biopsy-proven small cell lung cancer and IHC-proven small cell lung cancer, I'll be happy to take the treatment forward. I have my imaging. If I required the MRI brain, I have that imaging also. And with the small cell histology, I would be happy to go ahead with the treatment.
Fair enough. So, any inputs from Dr. Praveen Jain sir or Dr. Varun Goyal sir? Are you doing the standard tests like EGFR, ALK-ROS1, PD-L1, the way we are managing NSCLCs these days? So where are we in small cell carcinoma lung? Are we only happy with the biopsy report and then we'll start treatment after staging investigations, or you will go for those molecular biomarkers?
So what I am doing is that those patients who are either non-smoker or like light smoker, former smokers are there. So then obviously I am going ahead with EGFR, ALK-ROS also in these patients. And I have seen, I think, 2 patients of EGFR mutation were in small cell lung cancer, and 1 patient of ALK rearranged tumor also I have seen. And but most of these patients, they behave just like small cell rather than behaving as EGFR mutated or ALK rearranged tumor. So the behavior remains almost similar to the small cell lung cancer.
So very good, sir. Very good point you have got. Right.
And
Please,
even if some sort of molecular aberration comes out to be positive, then also the thing is that it doesn't change our management in the initial setting, and we obviously go ahead with the etoplatinum based chemotherapy, and maybe in these particular cases at the time of maintenance we can use these oral targeted therapies in a maintenance strategy.
Okay. Dr. Mukesh Patikar is there. Sorry, if I'm missing any of the co-panelists, or Dr. Shaina, if she have joined.
Dr. Sujna has joined. So Dr. Sujna
have joined.
Yeah,
may I take inputs from Dr. Sujna? So if we are having EGFR positive small cell carcinoma lung, suppose you have done a limited panel of like 12 gene panel or the coupon testing, which you are available at a very, very reasonable cost. And if you have figured it, like you're able to figure it out that this patient is a EGFR positive or ALK, as Dr. Praveen Jain sir have told. So whether your management will change or you will go ahead with the standard platinum-based doublet plus
No,
minus.
sir, I would go ahead with the standard treatment. I would
You'll
not
go ahead
add
with standard
any.
chemotherapy. Right. So will you be happy to use immunotherapy plus chemotherapy or only chemotherapy doublet in a patient who's having a molecular marker like EGFR positive, incidentally picked up? We know that immunotherapy won't work in
Targeted therapy.
Targeted therapy. So what is your input on that?
In small cell lung cancer, I have no idea, sir. We can extrapolate it from non-small cell lung cancer probably.
Okay. So may I ask Dr. Praveen Jain sir, in those patients in which you got ALK rearrangement, so how you managed, whether you have used immunotherapy plus chemotherapy or you have gone for chemotherapy only?
So fortunately, 2 of our patients, so they were not affordable for IO agents. But yes, one was affordable and we did not give that option. We discussed it with them that the point is that it's not going to work. And later on, like that patient was EGFR mutated. So we were having that concern also in our mind that post immunotherapy, if we plan to give osimertinib, so then there will be high chances of developing pneumonitis, because there is definitely data which says that post IO agents, if you give OC, then there are more chances of developing pneumonitis. So this concern was there, and we discussed, and the patient went with our advice only, and we just gave chemotherapy. So we have never used in all these 3 patients, we did not use IO plus chemo. So we used chemotherapy followed by 4 cycles of chemotherapy. We whatever best response we could have achieved, we achieved that, and after that we started with the targeted therapy maintenance.
Fair enough, sir. In that patient, like resource limited setting was there, maybe possible. Suppose the patient is affordable. My question is like whether you will be going for immunotherapy plus.
No, that's what I'm telling you. That's what I'm telling you, that if EGFR mutation positive tumor is there, so then it becomes an issue, because there is data where post durvalumab, when osimertinib was used in those patients, so there was more drug-induced pneumonitis in OC group vis-a-vis those patients who did not receive immunotherapy in the prior setting. So taking these things into consideration, I'll not be very, very keen in using IO along with chemotherapy in these particular patients. And see, we are getting only 2 months of median overall survival advantage with IO, vis-a-vis if we are able to use osimertinib as a maintenance in these particular. So we do not have any data in favor of maintenance osimertinib, but the thing is that extrapolating from other data, so it is a better strategy to use OC as maintenance rather than using IO along with chemo in small cell lung cancer.
Fair enough, sir. Aptly articulated. So is there any difference of opinion, Dr. Varun sir, Dr. Pankaj sir?
Sir, I have a bit of reservations in extrapolation of data in small cell from the other squamous or adeno. See, small cell lung cancer, according to me, is altogether a different game. So you cannot, from my personal opinion is, if you are having some EGFR, some mutation by chance, I think we do not have any data to support any change in treatment. Better we just forget it what it is, because we do not know how to apply that. Because there are different pathways, multiple pathways which are acting in small cell cancer. So we do not know whether it's a driver mutation or not, unlike the other adeno or squamous. So possibly I will not give importance to these mutations and possibly treat them as the way they should be.
No, Pankaj, the point is that you have taken just a small biopsy, and this is the reason why you are getting EGFR AL cross in these patients who are non-smoker, that probably there is tumor heterogeneity and there is some component of adeno also and some component of small cell also.
That is fine, but I think the small cell will be the one who will be deciding everything, and if there is any doubt, I'll better repeat a biopsy.
Post six cycle, you do not have any maintenance therapy available for small cell. Na? So now take the other example, that you have got a biopsy of adenocarcinoma. And at that particular time, so you have applied IHC marker also, and that marker shows presence of synaptophysin. and
Mhm.
that patient comes out to be EGFR mutated. So now
Mhm.
what are you going to do?
Now we have to, that is what, and we have to discuss what is the major component who will be operating on it. If it is a
So
small
in
cell, basically by chance you have,
small biopsy, you cannot say na major
so
component.
that is what I'll probably repeat a biopsy. If
Okay,
that is the
okay,
major
I
issue.
do agree. This is a debatable point. What Pankaj sir is telling and what Praveen sir is telling, no doubt about that. But on the whole, by and large, we know that extensive small cell carcinoma of lung carries dismal prognosis. Ultimate aim is we have to keep this patient as good as possible for as long as possible. We are having positive data in those patients who are EGFR or molecular target driven extensive stage small cell carcinoma of lung. For the time being, I think all of us are in consensus that we should try to stick to the guidelines and we should go for EP plus minus immunotherapy, depending on the correct clinical settings. I will move now forward for this patient. So this patient, I'll come back to the point that this patient was further worked up and CT guided biopsy from the liver mass have confirmed that the patient was having a metastatic disease. MRI brain was contemplated and there was no abnormal findings. And the patient's diagnosis was established that extensive stage small cell carcinoma lung with a liver metastasis, obviously. So Dr. Tanvi Sood, just a quick take, how you differentiate between limited stage and extensive stage as far as definition of how you decide what is limited stage and what is extensive stage?
So limited stage would be when it is an ipsilateral disease and it is in confinement of a tolerable RT field, whereas extensive would be anything beyond that, whether ipsilateral with lung nodules and disease that is in the hemithorax that is beyond confinement of RT field that is tolerable, or distant mets.
Okay, so ipsilateral pulmonary nodules are there in the pleura. So whether they will be confined in the radiation fields, whether you will take it as extensive stage or a limited stage. If they can be confined in the radiation portals, ipsilateral side only, some nodules are there which are looking suspicious. Whether you will go ahead.
Ipsilateral, if they can be confined in the same RT field, then we will take it as limited stage.
Fair enough. Fair enough. Moving next. So next question is, so what is your choice of platinum in EP-based regimen, whether cisplatin or carboplatin? Like in percentage, can you tell Dr. Varun in your practice whether you are happy to use cisplatin or carboplatin in majority of your patients?
So most of the time we use cisplatin only, etoposide and cisplatin as a first regime. But if any cisplatin ineligible patient, like there is some deterioration in the ejection fraction, like LVF is less than 40 and some significant papilloneuropathy, ototoxicity, some others like nephropathy and all. If we can't use cisplatin, we can change to carboplatin, but most of the time cisplatin.
Fair enough. So what question I want to ask Dr. Varun is, like, suppose the patient is having a DTPA GFR or the renal gram have shown that the GFR is 59 and patient also is showing that he's having light hearing loss, whether that will refrain you from using cisplatin, or hearing loss, is it a relative contraindication or absolute contraindication in a borderline GFR patient?
So about GFR, till 50, we usually give cisplatin. If below 50, then we avoid. About hearing loss, some slight hearing loss as such, patient also doesn't complain about that, and we also don't see for that. If significant hearing loss is there, then only, because it's not like that every, if any patient we are going to go for cisplatin, we are ordering audiometry. We are not ordering. So some slight hearing loss we usually overlook. We can give cisplatin in those patients also.
Sir, I'd like to add a point.
Yeah, Dr. Pankaj, please go ahead.
See, to my understanding, there's not a much big difference if you are choosing cisplatin or carboplatin. There's slight difference. So even if there is some problem, mild problem also, which can be like because of cisplatin, some hearing loss or some renal dysfunction, some doubt is there. I am happy switching to carboplatin rather than sticking to cisplatin.
Fair enough. So my question was pertinent, like if the patient is having a hearing loss, which the family is telling, so whether you will take as hearing loss as a criteria for cisplatin ineligibility, if cardiac function is okay, renal function is okay, or it's a relative contraindication and you will think about of using cisplatin, or you will be happy to use carboplatin only. May I take inputs from Dr. Srijna?
Sir, I would like to see which type of hearing loss. If it is a conductive hearing loss, we can go ahead. If it is a sensory neural hearing loss,
so
then
are you doing, Dr. Srijna, are you using Rene Weber test in your clinical practice? Can you be honest?
usually in head and neck cancers, we usually go for a bilateral audiometry, sir. Before
In
starting
thoracic oncology, I'm asking, like if you are having this type of scenario.
we do not go. Only based on the history we go, whether any hearing loss is there or any decrease in renal function by doing, according to the age of the patient, we prescribe the DTPA renal scan.
Fair enough. Dr. Tanvi, can you throw light whether hearing loss is absolute contraindication or a relative for cisplatin eligibility?
For sensory neural hearing loss, it would be a contraindication for cisplatin. But in this context, sir, I would also want to add that between carboplatin and cisplatin, in terms of efficacy, there is not much difference when it comes to small cell lung cancer treatment. So I would be happy to take up actually carboplatin in this scenario rather
Fair
than
enough.
go ahead with cisplatin.
Fair enough. So what are your views? Like how many cycles of platinum-based doublet you'll be using? 4 cycles, 6 cycles, or whether you will use irinotecan in those patients who are not ready to stay for 3 days in the ward because EP, or EC 3 days requirement is there. So can you use irinotecan first line?
So first line, we always prefer to offer a platinum with etoposide, and irinotecan is safe for a later line of therapy for progression. And we always try to give at least 4 cycles. If patient is tolerating well, then we complete 6 cycles.
Fair enough. Fair enough. So what is your input, Dr. Praveen Jain, sir? Have you ever used irinotecan in first line?
So most of the times we go ahead with etoposide, and as rightly pointed out by Dr. Tanvi, that so we have to make a treatment protocol, not in the first line also, we have to think about the second line also. So if we use first line irinotecan, so then the second line option which will be available to us is just oral etoposide can be given. So taking that thing into consideration, otherwise if you see the data wise, so irinotecan platinum versus platinum, so the efficacy is almost similar in both the regimes. So, but most of the times what we are doing is we are using etoposide platinum. We are using it for 4 cycles. Regarding the hearing impairment, so if patient is telling yes, I am having hearing impairment, or if you notice in your clinic that patient is having some hearing loss, then you usually go ahead with the audiometry, and it's not only cisplatin which causes hearing impairment, even carboplatin causes. So the chances of hearing impairment with carboplatin is slightly on the lower side as compared to cisplatin. And as far as my knowledge is there, it is not an absolute contraindication. You just have to do audiometry on your next evaluation also. And if it is showing that progressive hearing loss is there, sensory neural hearing loss, then you have to either stop cisplatin or you can switch to other platinum based regime.
Fair enough. Aptly said, sir. So in those patients who are having profound hearing loss and extensive small cell carcinoma, so along with etoposide, you will be happy to use irinotecan, or even then you will strike the attenuated doses of carboplatin.
So you mean to say eto plus irinotecan?
I'm asking single agent, or you will avoid platinum in those patients who are having profound hearing loss with extensive small cell carcinoma. How will you manage?
So if there is profound hearing loss, then also I told you that I will start with carboplatin. I'll do frequent audiometry, and we will see if patient is having severe hearing loss, then anyway he is not hearing anything. So if severe hearing loss is there, so then you do not have to compromise your oncological outcome at least. But if there is some mild hearing loss where there is tendency to get there is vulnerability for severe hearing loss, then you probably you monitor it more frequently, and if there is any progression in hearing loss, then only you will try to take off the patient from platinum based regime, I think.
Fair enough, sir. So I will come to the questions. Again, I already mentioned that. So what are the criteria in which you will use immunotherapy along with platinum-based doublet? So what are the do's and don'ts? Like, when is affordability is only the criteria, or is there any other? Like, are you doing PD-L1 in all the patients, or irrespective of PD-L1 you're using immunotherapy? Dr. Tanvi Sood, can I take input from you?
So we're not testing for PD-L1 in this setting, sir. So
okay. Dr. Varun, just specific answers. Okay,
No,
Dr. Varun, are you doing PD-L1?
In small cell, we are not doing PD-L1.
Dr. Sujna?
No, sir, we are also not doing.
You're not doing. Dr. Pankaj and Dr. Praveen, sir, are you doing PD-L1 upfront for all the patients or not?
Usually we discuss with the patient. If patient is ready, insists, he is very keen, then yes, otherwise no.
Patient will tell us whatever you say is best for me, sir. So what will your take?
If he say, there are people who will ask for NGS in first line, so we have to go by them.
Okay, okay. So it depends on the clinical case based. Okay. So would you still go ahead with chemotherapy in 2021 without IO? Right now we know that data, Caspian, Empower, all trials we know theoretically. So are we discussing, are we opening up that option in all the patients? Are you, whether your time in counseling is going more in extensive carcinoma upfront? Dr.
So
Tanvi.
there is
So there's not much progress in this space, sir, and this is the only advancement we've had in like many years. So definitely we've opened up the conversation, and now when we have small cell lung cancer patients coming in this kind of setting, we do tell them that there is immunotherapy option also, and it has some survival benefit to it. And definitely affordability plays a role. So as far as offering it goes, we are offering it to our patients now in combination with chemotherapy.
Fair enough, fair enough. So I will make it a little bit more complicated. I will tell the cost of each drug. Atezolizumab is available in 1,200 milligrams. The cost MRP is 3.96 lakhs. 4 cycles you have to give along with the chemotherapy. So the cost of 4 cycles will be 15.84 lakhs. If you use durvalumab is available in 500 milligram and 120 milligram. The cost of 500 milligram by MRP is 1.89 lakhs, and the cost of 120 milligram of durvalumab is 45,500 to be specific. So 4 cycles of durvalumab will be costing around 22.68 lakhs as far as 4 cycles, because after that only we are going to do reassessment. And if you are using without PAP, this is what I'm telling, without PAP, if you are using PAP, it will be 9.12 lakhs, right? And it is always 4 cycles is 15.84 lakhs. So durvalumab without PAP is 22 lakhs. So 6 lakhs difference is there if you talk about pharmacoeconomics. So are you discussing all this in detail upfront? My question is very, very specific, because
the first
now
thing we
the
talk about
financial
is
sustainability is going to take place, because this patient, you know that by and large, the overall survival is not 1 year. 50% of the patient will not be able to go for second line, and 30% only will be fit enough for third line. So are you doing the financial implication or the pharmacoeconomics is coming into play in your counseling?
Definitely, sir. It's something that has to be part of our counseling. And the more important part is we talk about the life expectancy. Definitely. So we leave it to the patients. We leave it to their wishes. They are aware that something is out there, and we let them know about the cost. And we foremost let them know what is the life expectancy, even despite all these efforts. What do we really expect at the end of 1 year? And then we leave it to the patient's wishes if they really opt for it. And we maybe in the past 2-3 years, I would have seen maybe 4 patients pick it up as an option.
Okay, in an affordable patient who's 80 years old, borderline performance status, will you be happy to use IO plus immunotherapy, whatever the marginal benefit of survival benefit you can give? Or you will be reserving it for a fitter younger patient?
Probably for a younger patient, 80-year-old, I would be skeptical even on the chemotherapy part, actually.
Okay, so Dr. Pankaj, sir, any input from your side? In an
So
elderly and fit patient?
somehow I feel there are class of patients who want a costly treatment. Even if you tell it's not worth, they have so much of inclination towards getting something costly done.
Yeah.
Maybe because of their social thing, or maybe they are having reimbursement, or whatever it is. Some people
Majority
are
of times, elderly patients are affordable and younger fitter patients are not affordable. So what do
because
you
you do not
in
want
that
to
scenario?
because they do not want to pass on the money to someone else before they go.
Dr. Naveen, sir, your input, sir.
So what we usually do, we usually counsel all the patients, obviously if there is no contraindication, but we don't emphasize on that. Like we try to emphasize that chemotherapy is the must, and second arm IO may or may not be taken depending on financial, and it should not be like that they have to borrow the money for that. It should not be like that.
Fair enough. So on individual basis, you have to take patient's preference into consideration. That's why even in extensive small cell carcinoma, the multidisciplinary tumor board is very, very important. You have to take patient's preference, his condition, what sometimes you can offer only single agent drug also if the patient is not having fitness for doublet. So all these things have to be judged on individual basis. Okay, so this is what I will come to the straightforward theoretical aspect right now. That prior to 2018, RCT failed to show any superiority as compared to the competitors. By and large, the median overall was hovering around 8 to 9 months, or by and large 10 months only. But now, after 2018, when the IO have come into picture, so the median overall survival have crossed 1 year, the median overall survival of durvalumab is 12.9 months, a hazard ratio of 0.75, and atezolizumab, it is median overall survival is 12.3 with hazard ratio of 0.76. So this is what theoretically, yes, you can say that they have to be discussed in all the patients, but we have to be very, very cognizant of the fact that these are financially toxic too. Okay, so Dr. Srijana, may I ask, in your practice, how many patients are eligible for second line? And is there any patient eligible for fourth line also? Have you encountered any fitter patient in which you have used fourth line? And what was the drug of choice?
No, sir. Maximum I have seen third line.
Okay. Dr. Tanvi, your input?
Sorry, sir, I didn't catch your question.
No, but I'm asking, have you ever used fourth line drug in extensive small cell carcinoma lung? Or majority of patients are in second or few in third line, they will succumb to the illness.
At most, it would be if patients are recurring after 6 months, we get the opportunity to use the same drugs as in first line, and maybe irinotecan after that. Beyond irinotecan, we've not been able to ever offer anything. Patients end up having some sort of complication and they succumb to the disease.
Fair enough. So, Dr. Pankaj sir, so if the patient is not affordable upfront and later on patient have got the money, so you'll be happy to use IO in the later lines, second or third line, or you will be reserving it your decision only for a first line?
Sir, see, I very much go with the patient's feelings and thoughts and expectations, telling that there is no data. Still, if you want to go ahead, please go ahead. We do not know. So if he says, okay, then okay. So it's like that.
Dr. Varun sir, your input?
So most of the time patient is not in the PS that we can give fourth line. Most of the time patient just get second line, and after that PS deteriorates and just BSC. But as Dr. Tanvi have told that maybe because of some DFI, maybe after some time recurrence, we have given second drug and then some more DFI. In that case, it's not like that. There is no contraindication. We can't give fourth line. If patient PS allows us, we can give re-challenge of ETO or something else.
Absolutely right, sir. I do agree what you told. But what my question is, like, if the first line you have not used IO plus platinum doublet, have you ever got a chance to use it in second or third line? Or majority patient deteriorates
IO re-challenge you are asking about, like
no, not re-challenge. You have not used in first line. You have used platinum doublet in first line. In second line, have you used IO?
Yes, in the second line we have used. If we haven't given as a maintenance in the after first line, we have used second line.
Fair enough, fair enough. So we can use it in second line also. So it's not like that it's only approved in first line. You can use in later lines also if the patient is affordable and if they are having expenses. So anyway, this all slides we know. So today, preferred regimen for primary therapy of extensive small cell carcinoma lung is carboplatin plus etoposide or durvalumab, or we call it DEC or DEP, and atezolizumab, etoposide, and carboplatin AEC is the only product. So we cannot use cisplatin with atezolizumab because the data is only with carboplatin, etoposide, and atezolizumab. So moving on to what are the criteria that can be considered while choosing IO in extensive stage. So what all patients you will use durvalumab, in what all patients you will use atezolizumab, whether you will go by pharmacoeconomics or the scientific evidence in choosing IO with chemo doublet. Dr. Tanvi, you can take it.
So, sir, if we do a cross-trial comparison, there's really not much difference in terms of efficacy. So, I really do believe this option and this preference would end up depending on what the physician, the treating oncologist is comfortable with, and also the support program that either of the two IOs would have, which one is less heavy on the pocket of the patient who is trying to opt for it. So apart from that, I'm not aware if there's any efficacy difference. The cross-trial difference, there's not much in terms of median overall survival.
Suppose like patient is ECHS beneficiary or CGHS beneficiary, they are okay with any of these drugs. So what will be your choice? How you will select? Because patient affordability is not an issue, right?
Patient affordability is not an issue there. So definitely, sir, because we started treating with atezolizumab first. It came, it came in 2019, and we have had 3 patients that we have done with atezolizumab, even in the second line for that matter. And now we have very good follow-up with durvalumab. So because we have the option of combining it with cisplatin as well, I think durvalumab would be a good option if we are able to use cisplatin and etoposide.
Fair enough, but majority of us are agreeing to this point that majority of the patients are not fit for cisplatin, although we are more inclined towards using cisplatin upfront. But 3/4 of the patients will not be fit enough because of whatever reason. We'll be using carboplatin because extensive stage small cell carcinoma lung, by and large, we know it's a disease of elderly. Rarely we'll find it in younger age group who are fit enough for cisplatin, isn't it? So major times we have to think twice before using. But anyway, what your point is valid, what you mentioned just now. And this slide, I think
in that case, I think we should toss a coin. If there is no, if there is no financial implication, obviously either of these two drugs we can choose anyone.
Fair enough. I think this slide we must have seen thousands of times. So this is the Caspian data which is compared with mPower 133. All comers, no biomarker selections for mPower 133. All were included. Same for Caspian. Untreated brain mets were excluded in mPower 133. That is atezolizumab trial. And Caspian, they were included. PCI was allowed in the control arm in Caspian, and only 10% of patients were included in mPower 133. PCI allowed in experimental arm, in which were 10% of the patients were included in mPower 133 and were excluded in Caspian trial. Up to 6 cycles of chemotherapy in the control arm was allowed for Caspian trial. For durvalumab, for atezolizumab, it was not allowed. And the flexibility of platinum, that whether you can use cisplatin or platinum, was only for Caspian trial, in which both can be given. But for mPower 133, only carboplatin was given. Cisplatin was not there. So these are the points which already we know. So I'm not going to detail that. Coming to the overall survival benefit. So median overall survival for infancy or durvalumab plus EP is 12.9 months, vis-a-vis EP it is 10.5 months, hazard ratio 0.71, favoring that these patients are going to do well if you use, and the responses are much more durable, as you can see in the Kaplan-Meier curve. So majority of patients have like 17.6% of the patient have crossed 36 months, right? If we do, ideally we should not do cross-trial comparison, but even then, by and large, if you see the median overall survival for atezolizumab platinum doublet, it is 12.3 months, and for Caspian trial, that is infancy or durvalumab, it is 12.9 months, and at 36 months, 17.6% of the patients were still alive and were taking the medication, and the overall survival benefit is only for 2 years for atezolizumab. This picture is very, very important. So is 2-year oral survival benefit is good enough to make the treatment choice for the sustained and durable response with IO? So whether you will be more inclined towards durvalumab because it's having a 3-year oral survival rate of 17.6%, and we are not having any data for atezolizumab as far as 3-year survival benefit is concerned. So Dr. Pankaj sir, so have you changed your practice now onwards, because durvalumab data is much more appealing? It is scientifically much more strong. You are having flexibility of platinum. So have you changed your practice in the last couple of years towards durvalumab plus EP?
I think we are having a stronger data with durvalumab as per this data. So slight tilt will be always there towards durvalumab. In the coming times, maybe we'll have further data with atezo, but present time, I think we have a bit of tilt towards durva.
Fair enough. Dr. Sujna, your inputs?
Yes, sir. I agree with what Dr. Pankaj sir has said.
Right. So majority of us are inclined to durvalumab if affordability is not an issue, right?
Yes, sir.
Fair enough. So we are having consensus on that. So next, so coming to the same patient. So first line, the patient was given etoposide and cisplatin as the performance status was good enough, and patient was cisplatin eligible along with durvalumab, financially affordable also. Patient completed 4 cycle and patient was in near CR with resolution of the liver lesions. So patient was on durvalumab for maintenance therapy, and patient was monitored closely with serial scans every 3 monthly with no evidence of progression. So now the question which is standing is, would you recommend PCI and or brain surveillance in patient with extensive stage small cell carcinoma lung and almost CR? So with a quick take from Dr. Sujna, can you tell whether you are offering PCI for all your patients?
Yes, sir. For extensive stage, we offer prophylactic CI if there is a good response.
Dr. Varun sir, whether you are going for brain surveillance only or for PCI for all?
So as such, all the data regarding PCI is before IO agent use. So after IO agent, although it has been seen in those trials that there is some brain penetration and there is some brain PFS improvement also with these IO use, but still till now there is no much data. So we also go for PCI if patient shows partial or complete response, and then we can continue with the government.
So I will be more specific. For limited stage, whether PCI is compulsory or extensive, it is optional. Are you okay with this sentence?
Yes.
Okay, Dr. Tanvi, do you agree with this statement? The PCI is optional for extensive stage, but it is compulsory for limited stage.
I agree with that, sir. So we have evidence now that in extensive stage when patients are in good response also, we can very well continue with MRI brain surveillance. And there was a Japanese study, in fact, that compared PCI with MRI surveillance versus MRI surveillance alone, and there was no OS benefit. So I know a lot of us still follow PCI for patients who are in extensive stage and good response, but MRI surveillance only is also an option. So to answer crisply, it's optional for extensive stage. Yeah.
Fair enough. So historically, PCA was recommended for all the patients with extensive stage small cell carcinoma lung after initial therapy with, which was based on the Slotman study, as you can see on the conclusion of this study. But without divergent data on the utility of PCI in this setting, the Japanese Takayashi et al. Study have demonstrated that there is no benefit of PCI in patients with extensive small cell carcinoma lung, has prompted reassessment for its role, and patient may use it nearly always or in certain circumstances, right? So this is what the literature is telling us. So I will come to the next question now, coming on to the thoracic RT. So may I ask?
So my apologies, sir. You are just left with 5 minutes to conclude.
Oh, I'm sorry. I'll just quickly take from Dr. Pankaj, sir, whether you are going ahead with the thoracic RT in those patients, or you are that thoracic RT is obsolete in your clinical practice for extensive stage.
I think,
Pankaj,
yeah. If they are having a very good response, then I think still we can try consolidation. It's not clear in this era, but I think we can still offer that.
Only yes and no. Dr. Varun, yes or no? Thoracic
No.
RT in extensive stage? No.
No.
Dr. Tanvi, yes or no? Question is straightforward in front of you.
Yes, sir. For residual disease only in the thorax and everywhere else, good response, thoracic RT consolidation.
Dr. Sujana, yes or no?
Yes, sir. In
Yes.
residual disease.
Okay, fair enough. So house is a little bit divided, but even then, majority of times we are going towards thoracic RT consolidation in this type of patient. But greatest benefit of thoracic RT is limited to the patients with residual disease after systemic therapy with less than 2 metastases. Okay, so this is what I will come to the end of this presentation. This patient is on dual maintenance and is under surveillance imaging using brain MRI for brain metastasis. So hypothetical scenario, if the patient was having a liver mets, had brain metastatic diagnosis, how would you manage? If the patient is having asymptomatic brain mets or symptomatic brain mets, whether your treatment will differ. Quick test from Dr. Sujana.
Yes, sir. If symptomatic brain mets, I would give first WBRT to brain. If asymptomatic, we can observe. When he becomes symptomatic, then only we can add the brain RT.
Fair enough. It depends on the volume of the disease, right? Isn't it? If the patient is symptomatic or not, high volume, low volume, what are the critical areas or not? Fair enough. So I will come to the next question, that what will be the choice of immunotherapy? That already you answered. So I will come to the Caspian trial. Already in those patients with brain metastasis, the median overall survival is 12 months, and the patients without brain metastasis, median overall survival is 13 months. Hazard ratio are quite significant. So this works very well in those patients with or without brain mets. Although the brain metastasis, the prognosis was not good enough. As you can see, the line of unity, the dots are on the right side, and in brain mets, it's on the left side. So this patient was kept on this 8-cycle patient accommodated without any progression. And as you can see, the Caspian trial have shown that 4 cycles of durvalumab along with platinum doublet, and if the patient is having a responsive disease, we can continue, and the frequency will be 4 weekly. This is what we have seen in observation on our practice. Patient will be coming after 4 weeks. It will be easy, and we can give. I think we must have used, and many of our patients are on this drug, and we will see in next coming years that how many of them will get a better prognosis. So that's the performance status come into play for decision making or the financial implication. So what will be your choice, Dr. Tanvi? In PS3-4, what will be your choice? PS2, just quick, can you tell me? Dr. Tanvi is not there, I guess. Dr. Sujana, can you take PS3-4?
PS3,
Yeah, Dr. Tanvi.
best supportive care. PS3-4, definitely best supportive care. I think I would counsel the patient for any treatment. Fair
enough. Well agreed. TMD and PD-L1 already we answered that it is not mandatory, but yes, you can be inclined. So to summarize, the first line durvalumab plus EP has shown a sustained improvement in overall survival compared to the robust control arm. It is reflective of real-world practice as it as it allows 6 cycles of EP and provided flexibility of choosing cisplatin or carboplatin along with etoposide. Benefit of durvalumab plus EP was observed across all subgroups, including brain mets subgroup, and survival tripled at 3 years with the use of durvalumab plus EP versus EP alone. Durvalumab offers convenient once monthly dosing regimen in maintenance phase, and safety finding remains consistent with the non-safety profile of durvalumab plus EP. So I think I've come to the end of my presentation. I think the message is very clear that now the practices have changed. And there are many more trials in the pipeline which are going to change, which are going to complicate the discussion in next coming webinars, because there are so much research is going on in how to extend the survival of this patient, which carries a dismal prognosis, isn't it? So ultimate law of oncology is we have to keep this patient as good as possible for as long as possible, isn't it? Thank you. Thank you very much.
Thank you, Dr.
Thank you.
Thank you, sir.
Thank you.
So with this very well conducted and moderated panel discussion, so now we will we have come to end of this session, and so we have seen 2 days of very well conducted and very informative oncology update session. And so I thank you all the faculties for their inputs and their help to make this meeting a success. And I thank all the panelists of both the day panel discussions for their expert comments and expert inputs. So then I thank all the attendees also, and for attending these 2 days session. And then in the last but not the least, I thank software partner Horizon for conducting this meeting, and all the pharma support. On the basis of that, this meeting has been done and had been very successful. So then with that, I will close today's session, and we will conduct these type of meeting in the future again. So thank you all, and good night.
Thank you. Thank you, everyone.
Thank you.
Happy
Thank
to
you very
help
much.
you. Thank you.
Thank you.
Good night, everyone. So we end the meeting for all. Can we go offline?
Yes, I think. Good night.
Good night, sir.